Welcome to the Deep Dive. We're your MCCQE guides, ready to help you conquer the exam. I'm Harvey.
And I'm Jonna. As fellow reviewers for the MCCQE, we know just what it takes to ace those tough questions.
Today we're taking a deep dive into a symptom that's practically a household name, the cough.
It might seem simple, but trust me, there's a lot more to it than meets the eye.
We'll be using top-notch sources like StatPearls, the gold standard for exam prep. And before we get started, just a quick reminder that this is for educational purposes only, not medical advice.
Absolutely. Always consult with a qualified healthcare provider for any health concerns. Now let's get down to business. What exactly is a cough?
Well, at its core, it's a reflex, right? Our body's way of clearing out those pesky intruders from our airways.
You got it, and it's a powerful one at that. Did you know coughs can expel air at speeds exceeding 500 miles per hour?
500 miles per hour. That's incredible. It's like a tiny hurricane in our throats.
Exactly. But with so many different types of coughs, how do we even begin to make sense of them all?
That's a good question. Where do we even start?
Well, the first clue is the cough's duration. We categorize them as acute, lasting less than 3 weeks, subacute, lingering for 3 to 8 weeks, and then those stubborn chronic coughs hanging around for over 8 weeks.
Okay, so duration is key. So let's tackle those acute coughs first. What are some of the usual suspects behind those sudden coughing spells?
You know, the common cold is always a top contender.
Ah, yes. Those viral upper respiratory infections always seem to come with a cough, sneezes, and runny nose combo.
Exactly. And then there's acute bronchitis, which is usually viral but can sometimes be bacterial.
Right. Most cases clear up on their own with rest and symptom management, but I remember learning that bacterial bronchitis might need a little extra help from antibiotics.
Absolutely. Now, shifting gears a bit, we have pertussis, or whooping cough, which is another cause of acute cough. Remember that classic whoop sound?
That's pretty distinctive. But what makes it so dangerous, especially for infants?
It's those intense coughing fits they get. The whoop sound actually happens when they try to gasp for air after a severe coughing episode. And those fits can lead to some pretty serious complications, like pneumonia, seizures, even brain damage. That's why vaccination is so crucial.
A scary reminder that something as seemingly common as a cough can take a serious turn. Now, you mentioned earlier that a pulmonary embolism could also be behind an acute cough. What's the link there?
So imagine a blood clot, often from the legs, traveling to the lungs and getting stuck in a pulmonary artery. It's like a traffic jam in your lungs. This blockage causes pressure to build up, fluid accumulates, and that triggers the cough.
Ah, so it's the body's way of reacting to that sudden disruption in blood flow. Pulmonary embolism is definitely something to take seriously. Now, let's move on to those coughs that just won't quit, the chronic ones. I imagine those are a bit more of a puzzle to solve.
You're absolutely right. Chronic coughs often require a bit of detective work to figure out the underlying cause. One common culprit is upper airway cough syndrome, which is essentially post-nasal drip.
Post-nasal drip. So you mean those sniffles that just won't go away?
Exactly. It might seem like just a minor annoyance, but that drip can irritate the throat and trigger a persistent cough, especially at night when you're lying down.
Interesting. So it's not the mucus in the lungs causing the cough directly, but the irritation in the throat. What about other common causes of chronic cough? I've heard GERD can be a sneaky one.
Oh, you're right on the money. GERD, or gastroesophageal reflux disease, is a major player in chronic cough. And here's the kicker. Up to 75% of people with GERD-induced cough don't even experience heartburn.
Wait, really? So they're coughing, but no burning sensation in the chest. How is that possible?
It's because the stomach acid that refluxes back up can sometimes reach the throat and airways, triggering that cough reflex without actually causing the classic heartburn.
GERD is a tricky one then. Are there any other potential culprits we should be aware of?
Oh, the list goes on. We also have things like non-asthmatic eosinophilic bronchitis, chronic bronchitis, post-infectious cough, and even a cough caused by ACE inhibitors, which are commonly used to treat high blood pressure.
Okay, so there's quite a spectrum of potential causes, ranging from relatively mild to more serious. It sounds like figuring out the root cause of a chronic cough is crucial for effective treatment.
Absolutely. And that's where a good diagnostic approach comes in, which we'll dive into next.
So we've explored how coughs are categorized and some of the key culprits behind them. Now let's put on our detective hats and talk about how doctors actually go about diagnosing the cause of a cough. I imagine the approach might differ depending on whether it's an acute cough or a chronic one.
You're absolutely right. For those acute coughs, like the common cold, it's often a matter of managing the symptoms and letting the illness run its course.
That makes sense, but are there any red flags with acute coughs that would warrant a closer look? Something that would make you think twice about simply managing symptoms?
Definitely. If a patient has a high fever, is coughing up blood, or is having trouble breathing, those are signs that something more serious might be going on and further investigation is needed. A chest x-ray would be a reasonable next step in those cases.
Okay, so it's about striking a balance between watchful waiting and knowing when to dig a bit deeper. Now, what about those coughs that just won't quit, the chronic ones? I imagine those always require a more thorough workup from the get-go.
Absolutely. Chronic coughs are where the real detective work begins. A chest x-ray is usually the first step to rule out any obvious structural issues in the lungs. And pulmonary function tests would be done to assess how well those lungs are working.
And if those tests don't reveal the cause, I'm guessing a specialist might be called in.
Exactly. A referral to a pulmonologist, a lung specialist would be the next step. They have a whole range of specialized tools to help pinpoint the cause of that chronic cough.
What kind of tools are we talking about here?
Well, one common procedure is a bronchoscopy, where a thin, flexible tube with a camera is inserted into the airways. This allows the doctor to get a direct look at the lungs and even take samples if needed. They might also order a CT scan for a more detailed image than a standard X-ray can provide.
So there's a whole arsenal of tests to help get to the bottom of those stubborn coughs. And once you've identified the cause, I imagine the treatment strategy hinges on addressing that underlying issue.
You hit the nail on the head. It's not just about suppressing the cough, it's about tackling the root cause to truly resolve the problem. Let's take GERD-induced cough as an example.
Right. You mentioned earlier that many people with this type of cough don't even experience the typical heartburn symptom. So how would a doctor even suspect GERD in those cases?
A thorough history and physical exam are key. Asking specific questions about symptoms like a sour taste in the mouth, hoarseness, or the feeling of something stuck in the throat can be incredibly helpful.
So it's about listening carefully to the patient's description of their symptoms and piecing together the clues.
Exactly. And if GERD is suspected, a trial of acid-reducing medications might be recommended to see if the cough improves.
That makes sense. But what if those medications don't work or the diagnosis is still uncertain?
Well, in those cases, more specialized testing might be needed to confirm the diagnosis. An upper endoscopy, where a thin scope is inserted into the esophagus and stomach, can help visualize any abnormalities. Or esophageal pH monitoring can be done to measure the level of acid reflux over a 24-hour period.
So it's a multifaceted approach, using different tools to either confirm or rule out GERD as the culprit behind that cough. This is fascinating stuff. But I know we can't spend all day talking about GERD. Are there other chronic cough culprits where addressing the root cause is just as important?
Absolutely. Asthma is another great example. While we often associate wheezing and shortness of breath with asthma, some individuals primarily experience a persistent cough, especially at night or after exercising.
Ah, so it could be a bit of a cough chameleon too. How would you differentiate a cough caused by asthma from other types of coughs?
Again, taking a careful history is essential. Asking about triggers like exercise, cold air, or allergens can provide valuable clues. And pulmonary function tests, specifically spirometry, can reveal those characteristic patterns of airway obstruction that point to asthma.
So it's about putting together those puzzle pieces, the patient's symptoms, their history, and the results of specific tests to arrive at the right diagnosis.
Exactly. And once asthma is diagnosed, the treatment focuses on controlling that underlying airway inflammation using inhaled corticosteroids or other medications as needed.
This is all so insightful. We're really getting a deep dive into the world of cough diagnosis and management, and I'm sure our listeners are absorbing it all. Now, what about those coughs that seem to linger after a cold or other respiratory infection? Anything specific to keep in mind for those cases?
You're referring to post-infectious cough, which is surprisingly common. Sometimes, even after the initial infection has cleared up, the airways remain hypersensitive and irritable, leading to that persistent cough.
So the cough itself is no longer fighting off an infection, it's more of a lingering sensitivity.
Exactly. It's like the cough reflex is stuck in overdrive. In these cases, reassurance and time are often the best medicine.
So sometimes the best approach is simply explaining to the patient that their body is still in the process of healing and that the cough will eventually subside on its own.
Absolutely. And of course, providing symptomatic relief with cough suppressants or other therapies can help improve their quality of life while they wait for the cough to resolve.
This has been incredibly helpful. We've covered so much ground, from coughs caused by the common cold to those triggered by underlying conditions like GERD and asthma. It's clear that a cough is rarely just a cough. It often has a deeper story to tell.
Couldn't agree more. And for our listeners who are prepping for the MCCQE, I hope this deep dive has emphasized the importance of a systematic approach to cough assessment. You need to consider a wide range of potential causes and focus on targeted treatment.
Before we wrap up with a look at those environmental factors that can contribute to chronic cough, are there any key takeaways you'd like to emphasize for our listeners?
I think one of the most important takeaways is to really listen to your patients. Their description of their cough, their associated symptoms, and their medical history are all crucial pieces of the puzzle.
It all comes back to those core clinical skills: observation, active listening, and critical thinking. Now let's shift gears and explore those environmental factors that can play a role in chronic coughs. We've been on quite the journey through the world of coughs, haven't we? From those quick, acute ones to the chronic coughs that really make you put on your detective hat. And before the break, we were talking about how important it is to treat those chronic coughs by tackling the root cause, not just masking the symptom. Now let's talk about something you brought up earlier, the role of the environment in chronic coughs. It's fascinating to think that our surroundings can have such an impact on our health, especially when it comes to those stubborn coughs.
You're right, it's easy to get caught up in the internal factors, but the environment can be a major player, especially when it comes to those coughs that just won't quit.
That makes a lot of sense. I mean, our airways are constantly interacting with the world around us, filtering everything we breathe in. So what are some of those environmental culprits we should be aware of?
Air pollution is a big one, especially for people in cities or areas with poor air quality. Think about all the stuff that gets pumped into the air: car exhaust, factory emissions, even smoke from wildfires. All those things release tiny particles that we end up breathing in. And those particles, known as particulate matter, they can really irritate the lining of our airways, leading to inflammation and, you guessed it, a cough.
So it's not just about having a pre-existing lung condition. Even healthy individuals could experience a cough if they're exposed to polluted air for a long period.
Exactly. It's like a constant assault on the respiratory system. And it's not just about outdoor air pollution either. Indoor air quality can be just as problematic.
Oh, interesting. What are some common sources of indoor air pollution that might contribute to chronic cough?
Well, there's secondhand smoke, of course, and dust mites, mold. Even certain cleaning products can release irritants into the air inside our homes and offices.
So it's not just medications and lifestyle changes. Managing a chronic cough might also involve taking steps to improve the air quality in our homes and workplaces.
Absolutely. For someone struggling with a cough that just won't go away, especially if other causes have been ruled out, it's definitely worth considering their environment as a potential trigger. Things like using air purifiers, making sure there's good ventilation, and avoiding harsh cleaning chemicals can make a big difference.
Those are some really practical tips that are often overlooked. It's a good reminder that health is not just about what's happening inside our bodies, but also about the environment we live in. Now, you also mentioned allergens earlier. I know those can be major culprits behind coughs and other respiratory symptoms. How do allergens factor into the chronic cough picture?
Well, allergens like pollen, dust mites, pet dander, and mold spores, they can really irritate the respiratory system, especially for people with allergies. When someone with allergies breathes in these triggers, their immune system goes into overdrive, releasing all sorts of chemicals that cause inflammation in the airways.
And that inflammation leads to those classic allergy symptoms.
Yeah.
The sneezing, runny nose, itchy eyes, and of course, the cough.
Exactly. For some people, the cough might be the most prominent symptom, so it might seem like they have a never-ending cold or bronchitis when it's actually an allergic reaction.
So how do you tell the difference between a cough caused by allergies and one caused by something else?
Again, a thorough history is key. Asking about when the cough happens, whether it's seasonal or worse at certain times of day, or triggered by specific exposures like being around pets or certain plants, can give you some valuable clues.
It's like putting together a puzzle, gathering all the pieces of information to get a clear picture of what's going on.
You got it. And if allergies are suspected, allergy testing can help pinpoint the specific culprits. Once those triggers are identified, the focus shifts to minimizing exposure and managing the allergic reaction with medications like antihistamines or nasal corticosteroids.
This has been such an eye-opening conversation. We've covered so much ground, from the basics of coughs to their complex causes, and the importance of looking at the whole picture when it comes to diagnosis and treatment. Before we wrap up, any final pearls of wisdom you want to share with our listeners, especially those getting ready for the MCCQE?
Well, always remember that the MCCQE is all about testing those clinical reasoning skills, that ability to think critically and put all the pieces together. And when it comes to coughs, don't forget that they're rarely simple. Be prepared to think broadly, ask the right questions, and dig deeper to find those underlying causes, whether they're medical, environmental, or a bit of both.
What a great reminder. The best doctors are the ones who approach each patient with curiosity and a genuine desire to understand the whole person, not just the symptom they're presenting with. And with that, we want to thank all of you for joining us on this deep dive into the fascinating world of coughs. Keep those brains working, keep asking questions, and keep exploring the amazing world of medicine.